Good evening. I'm Charlotte Jackson, president of the Camille Rose Georgia chapter of the Links Incorporated. And today we are so pleased to honor survivors of breast cancer by bringing you this panel on regarding breast cancer in observance of Breast Cancer Awareness Month. Moderating our panel today will be Joy White. She is a member of Camille Rose Georgia chapter of the Links Incorporated, and she is also a healthcare professional. After graduating from Clark Atlanta University with her degree in biology and getting her master's in public health administration from Albany State University, she has worked her way up after 25 years in the healthcare strategy arena to be the national vice president of network strategy for United Healthcare. And so she is going to help bring out the expertise of the wonderful medical professionals that we have to provide you all the information that you need. Thank you, Joy.
Thank you, Charlotte. Thank you for that introduction. Good evening, everyone. We have three dynamic medical professionals who will be joining us tonight, to talk about all things around breast care awareness. First, I have the honor and pleasure of introducing Dr. Erin Bowman. Dr. Bowman has joined Atlanta Breast Care in August of 2013. A Philadelphia native, Dr. Bowman graduated from Spelman College with a Bachelor of Science in Biology and considered Atlanta to be her second home. She earned her medical degree from Boston University School of Medicine and completed her residency in breast cancer surgical oncology and a fellowship from both Boston University and Morehouse School of Medicine. Dr. Bowman is a board certified by the American Board of Surgery. She's a member of the American Society of Breast Surgeons and the Society of Surgical Oncologists. Dr. Bowman, thank you for joining us.
Thank you for having me.
Next, we have Dr. Contessa Metcalf. Dr. Metcalf was born and raised in Kansas City, Missouri. She grew up being involved in every activity imaginable and being crowned her high school homecoming queen. Dr. Contessa attended and graduated from Xavier University, where she got her undergraduate degree, and for medical school, she went to St. Louis University. Dr. Metcalf is also a flight surgeon and completed her residency at the Naval National Medical Center. In addition to owning her own medical concierge service called Acute Face MD, she is also, in her spare time, a restaurant owner and a real estate entrepreneur. Dr. Metcalf, thank you for joining us.
Sorry, I was muted. Thank you so much.
No worries. And lastly, but definitely not least, Dr. Miller Thrasher was born and raised in New York City. Dr. Thrasher received her undergraduate degree in biology and nutrition from Cornell University, and she did her residency at NYU. With 22 years of experience to her credit, Dr. Miller Thrasher opened the Innovative Women's Healthcare Solutions, a practice that presents the best of the 21st century cutting-edge technology and medical advances along with alternative methods as a part of a balanced plan for enhanced medical care. Dr. Thrasher, thank you for joining us this evening.
My pleasure.
Ladies, we want this to be more of a conversation versus a question and answer session. I'll pose questions to each of you, but as we do in true sister spirit, if anyone feels the need to add on, please do. The more information we can provide to our listening audience, the better it is for all of us. And I will start with the real, some would say basic question, but a real good one. And Dr. Bowman, I'm gonna start with you. What is breast cancer?
So breast cancer is cancer that occurs in the breast, but taking it a step further back to what is cancer. So cancer is when there are cells that are in the body, and the body's made up of cells that are abnormally growing without any control. So there's an overgrowth of these abnormal cells that are not getting checked, and it forms into a tumor. And so cancer cells are those overgrowth of those abnormal cells.
And what are the different types of breast cancer?
So there are many types of breast cancer. The two most common, so that we start at the top, are when you have what's called in situ or in situ disease, which is non-invasive or pre-invasive, and then there's invasive. And then we break that down even further to what types or subtypes of the invasive there is, and which is ductal and lobular. There's even more characteristics that we can go into, but for the basis of tonight, this panel, the most common breast cancers are ductal and lobular invasive. And then pre-invasive is something called ductal carcinoma in situ.
Thank you. Dr. Metcalf, what are some symptoms of breast cancer?
Well, unfortunately, for a lot of people, there are no symptoms, and so the best thing to do, and I'll defer to the the specialist. The best thing to do is to have a screening mammogram. Now, it's different schools of thought about when that happens, but if you're a woman that's over 50, you should have had a mammogram by now. My mom actually was one of the unfortunate ones who had breast cancer in her 20s. But between 40 and 50, the United States Public Health Service recommends essentially it being your decision. But I mean, I would actually still recommend women get a breast mammogram at 40. But again, I'll defer to the specialist to see what they say. But I practice preventive medicine, and so we follow the USTSPF. And a lot of times I go against my peers, and I recommend at 40 women get a mammogram. So a lot of times people think the symptoms like a lump or pain or things like that are breast cancer, but actually most symptoms are not associated with breast cancer at all. And so the best thing to do is to get screening.
Thank you. Dr. Thresh. Oh, go ahead. I'm sorry, go ahead.
No, I was just going to chime in on that. I would agree completely with that, that most commonly there are no symptoms. But it doesn't mean, and like she said, most of those, when you find like a lump or have nipple discharge, it could be, most commonly, it's something that's benign, but it's still something that should alert you to talk to a healthcare professional about. And then agree with the mammography age. We recommend age 40 unless your family history dictates that you need to start sooner. Which would make you high risk, but that's something that also would be determined by a healthcare provider. But completely agree that there are some recommendations by certain groups that I go against as well.
Kind of staying on that same topic of risk, Dr. Thrasher, for those who may be considered high risk by genetics, either in breast cancer or other types of cancer, A, is there a recommendation, again, on when to start that screening? And B, would you have that same recommendation if you have a history of other types of cancers other than breast?
So I agree with the recommendations previously stated by the other panelists, and we typically do start at age 40, which is the recommendation. But again, depending on family history or if they have other mitigating factors, we can start earlier. So let's say your mother or first degree relative had breast cancer at age 40, then, literally what we would recommend is that you start 10 years prior. So she would start perhaps at age 30. So all of those things, that's why it's really important to have a health history, to go in and see a healthcare provider, because otherwise people are so misinformed about when they should get started. And one of the things I hear a lot of people saying is, well, I don't have a family history. But 80% of all breast cancers or even more occur in people with no family history. So I think people look for an out for not getting a mammo. It's not a painful exam, but still people are very sort of, culturally, just like the vaccine thing, there are people who just don't want mammos. And so we have to constantly talk to them about why it's important, why you won't be able to feel everything that is problematic. And as a matter of fact, at the point that you feel it and it is cancerous, then that's really way too late. So what we advocate in our practice is a 3-prong approach to early detection. Number one would be see a healthcare provider. It doesn't have to be me. It doesn't have to be a specific breast surgeon, but you do need to have a healthcare provider do an objective examination on you yearly. Number two, self-breast examination on yourself, because the vast majority of breast lumps are found by the patients themselves. And number three, to, sort of like supplement that definitely with imaging so that you can see things that are not palpable and things that you can catch really early. So that's sort of how we counsel our patients. Let me know if there was part two that I didn't get to.
No, actually you did. You did. Thank you very much.
Okay.
Dr. Metcalf, from a preventative medicine standpoint, what are some suggestions that you will offer to our audience outside of the screening process from a mammogram perspective? What type of suggestions or recommendations would you provide to the ladies and or the families who are listening around preventative alternatives and measures around breast cancer?
Well, one of the major risk factors that people sometimes forget in just regards to just cancer in general is obesity. Obesity is a big problem, and so making sure that you're maintaining your weight and a healthy BMI, your BMI being 25 or less, and again, managing that, exercising on a regular basis, eating mostly a plant-based diet. Those are things that are definitely protective in regards to cancer in general. And some of the things that just women who are concerned about their risk, some of the things that put you at a higher risk are if you're a woman who's never actually been pregnant before, or if you were older than 30 when you did have your first pregnancy. Those are things that actually put you at a higher risk. And when you started your period, that's really something that's very interesting, that if you started your period pretty young, your risk is higher. And I think young is, and it's again, I defer to the specialist on this, but somewhere between 12 and 13 years old, if you were younger than that, then that actually increases your risk as well. And if you didn't breastfeed, so breastfeeding is a protective factor. It's good for the baby, but it also protects you from getting breast cancer. And so those are the kind of things that if you are a woman who's a younger one who's listening and are of childbearing age and you are, considering having a baby at some point, breastfeeding is actually protective for you. So anything that you can do to essentially lessen your risk of illness, keeping your body as healthy as it possibly can, that can help. There are a lot of things that we don't think about when it comes to cancer in general that I always am really curious about as a preventive medicine doctor is environmental toxins and environmental exposures. And I think the data is really not great on how much of an impact that has. But there is a reason why Black women in particular are more likely to have a more aggressive cancer. And I don't know, and I guess this is something that I think the specialists again can talk about as far as the environmental things, whether it be exposures from some of the choices of our foods or where we live or, those kind of things. But there's a lot of, I think there's a lot of work to be done when it comes to that, what you're exposed to in your environment. But if you are maintaining your weight and doing your best to make sure you eat a mostly plant-based diet, pretty healthy, not a lot of processed foods and things of that nature, that's going to definitely help to prevent any of those, is going to lower your risk of cancer overall.
Thank you. So once we talk about screenings, we talk about possibly risk. Now let's talk a little bit about a little reality, a person's reality. So now a diagnosis has been confirmed of breast cancer. Dr. Bowman, what are some recommended next steps for that lady who's kind of in that moment of, this is what I'm hearing, this is what I need to process, how should I move forward?
So next steps will be first talking to her healthcare provider, whether it's her primary care doctor, OBGYN. Somebody's going to give her that diagnosis after a biopsy was done. Sometimes it's the radiologist calling from the breast center where the biopsy was done. The next steps are going to be referral to a breast specialist. And that's generally what I do as far as being breast surgeon. I'm kind of the next step in that process where someone will come to me and then we sit down, and I typically sit down with a patient when they have a new diagnosis for at least an hour, and we go through everything. I talk about all the treatments, and basically the treatments are based off of different things that we learn from that diagnosis. So you get the original diagnosis. Yes, you have breast cancer, but then there are several factors that we have to test for to determine, is this a cancer that is related to hormones or not? Is it have something called a HER, HER2 new protein on it or not? Or is it more aggressive or not? Do we need to start with surgery, or do we need to start with medical therapy, which would be chemotherapy first? And so basically all of those things come after we learn all the details, all the characteristics of the cancer.
Mhm.
But generally, the next step after your diagnosis is referral to that breast specialist. And then the breast specialist kind of plays as your kind of quarterback of your team. And so they're going to start that process, that treatment plan development, and then refer you to other people, like maybe a radiation oncologist, a medical oncologist. And then also, typically, if any additional studies have to be done, like a breast MRI or a CAT scan or what's called a PET CT, which is going to be a body scan to see if there's cancer anywhere else in the body, then that can also be done. So it's a lot of workup and a lot of details, a lot of information for patients. So it's really good to kind of find that one person who's your point of contact that can then lead you and guide you along this treatment path. And so that's generally what's next is a referral to a specialist.
Thank you. Dr. Thrasher, hearing all that a woman has to digest based on what Dr. Bowman just iterated, is it smart? And if so, when should you possibly get a second opinion?
I always counsel patients that a second opinion is never a wrong decision. However, if they feel completely comfortable, some patients can feel completely comfortable and want to move forward as soon as possible. Others, even if the diagnosis is more dire or more concerned and want a second opinion, I never discourage. I always encourage, and I always tell them whatever decision you decide, I will help you. I will help expedite it. I will be your advocate. You know, I really try to help them process it in bits and pieces. And so I think it's something that somebody would want to get for the most part. It's a huge decision. It's a huge diagnosis. And so again, I encourage it. Not everyone, you know, takes the bait, but I strongly encourage them to consider it.
If we think
Can I add
about,
to that?
go ahead.
I'm sorry.
Oh, go ahead.
Just
Go ahead.
about the second opinion, I completely agree, and I welcome it as well. And I always tell patients, if you're not getting your questions answered, if you still have any kind of sense of doubt, if you're just not feeling comfortable, you should get a second opinion. There shouldn't be a lot of change as far as the treatment plan, but it's you know, your gut feeling. This is someone that's going to take you to surgery, right? Put you to sleep and cut on you. So you have to be comfortable with that person. And you have to feel like that person is not only on your team, but is going to fight for you as hard as you're going to fight for yourself. And so if you think that person is not that one for you, then you should definitely seek another opinion.
I absolutely greatly appreciate that piece. I will also want to switch gears just a little bit. And let's talk about, I'd say, a part of like integrated medicine. So we talked about meeting possibly, you know, with, radiation oncologist, possibly with your medical oncologist. But what other types of professional services do we want to think a full wraparound, if you will? So let's talk a little bit about nutrition. And one thing that's really kind of big and near to dear to our heart of our chapter, mental health, and how mental health is integrated into this entire, I'd say, journey of a woman who's been diagnosed with breast cancer. And that's for anyone who wants to chime in on that one.
I can start with it. I know that at least with me, with my group at Piedmont, and my practice is Atlanta Breast Care, but we have a cancer wellness center that has many, many resources for patients. Answer any questions, and it's a free resource to patients. So it's not something that you have to pay for. But the nutrition is a huge aspect of not only, at your diagnosis, but for prevention in the future. So there are different diets, like Dr. Metcalf talked about the plant-based diet, but certain things that you can include in your diet to lower your chance of breast cancer for prevention in the future. The mental health aspect of it is huge. And I feel like this is something that is coming up more and more. You know, it's always been like a secret to, about mental health, but we advocate for it. I have a psychologist who is an oncology psychologist in my office that does only cancer patients, and not just breast. She caters to all different types, but she does a lot of breast cancer patients to help with them going through this process, whether it's a new diagnosis or for patients who dealt with it 5, 10, 15 years ago and still having issues. It's a lot to go through a cancer diagnosis. For women every year when they go back and get their mammogram, if they still have their breast, it's like PTSD for a lot of women. Something that should not be ignored.
Thank you. Still along the trajectory of nutrition and wraparound services, Dr. Metcalf, if you could talk to us a little bit about when patients want to seek true alternative medicine as a result of a cancer diagnosis. Go ahead.
All of us you see all of our faces kind of like scrunched up. So I actually have here in Buckhead in Atlanta, integrative medicine clinic, and I'm a big advocate of, I call them more complementary medicine. And I think that's important because, people are very interesting when it comes to kind of alternative and complementary medicine. Your insurance covers anything that has been data driven, that's based in science and research, right? Because there's no way that people are, the insurance company is going to pay for something that hasn't been shown to work. However, people will spend all their money on paying someone thousands of dollars for something that is just all kind of based in nothing, based on word of mouth, or kind of just random kind of wives' tales. So I, unfortunately, am a big advocate of using science to guide your decisions to what you do, right? So if you do want to try something, like for instance, some kind of herb, or you go to the herb man, or somebody who sells something out of their car, or out of some little random shop with supplements in their water and things like that. So you got to worry about, there's toxicities that are for medicines and for things that are on the shelves and usually in stores and things like that. They are regulated, and so that they're not toxic. But when you are just getting something randomly, you don't know what's in it. You don't know if it's actually anything that it says it is, right? I mean, famously, there was a lot of, like, that's now why fentanyl is actually causing overdoses, because people, can easily put something in anything that you're getting, and you have no idea what you're taking. And so, number one, if you are taking supplements, if you're getting something off the internet, if you're buying something overseas, or you're getting something from somebody, make sure you tell your clinician, because what people also don't remember is that medications, drugs, treatments are based off of herbs. And so a lot of times what you're taking actually can not only, affect what you are taking, like medically, or your treatment, it can actually undermine it, or even actually make it not work at all. And so if we don't know that, or even worse, if something that you're taking, really interacts with some herb or some other vitamin or something that you're taking, it can build up in your body to a toxic level. And so that's something just to be concerned about overall. I mean, you got to just really be really careful. And I have never told somebody, if something is safe, not to take it, right? But we do need to know. We need to know if we're prescribing something, or we're giving you something that is going to counteract, or worse, make something that you're taking even more potent than it should be, or less potent. So just talk to your doctor. We're not your enemy. We have no problem with you taking other stuff. And if it's clinically sound, we're going to tell you. We don't make any money from prescribing you medicine. We don't make any money from, chemotherapy, radiation. We don't make any money from that. There is no benefit. We're bound by our degrees, by our licenses, to not do harm. And so we're going to protect you. That's our job, first and foremost. And we believe also in autonomy. Whatever you want to do, whether you choose to get no treatment whatsoever, because for some people that's their solution. They decide to do no treatment. That's what hospice is. If they're at a point where the treatment is not beneficial. So all those things just kind of tell you that as clinicians, we're not your enemy. So do let us know every single thing that you're putting in your body, so we can give you the best information that we have to make sure that it's safe and effective.
Thank you. As we talked about, diagnoses, we've talked about screenings. Let's talk a little bit about technology and innovation. So, Dr. Thresher, if you will, can you talk a little bit about what are some of the latest innovations around breast cancer treatment and screening?
I know Dr. Bowman would be like phenomenal at answering this. I completely defer to Dr. Bowman on that one.
Okay.
So there you go, my sister.
So the thing about breast cancer is it changes, I feel like, daily. So treatment changes based off of studies that are done. I think probably more common as far as like surgical management, there are, well, many people don't know it, but you don't have to remove your whole breast to treat breast cancer, right? So that's actually something that's been done for decades. But I think one of the common myths is whenever someone's diagnosed with cancer, they always come in and say, just take both of them off. And it's like, we don't have to do that. And you can have an effective treatment with not removing your whole breast and have the same overall survival and prognosis and outcome as if you were to remove your whole breast. We don't have to remove all lymph nodes anymore. So we check for what's called the sentinel node. And the sentinel node is like gatekeeper lymph node. That's the first lymph node that would be affected by any cancer. And so we check that lymph node. If that lymph node doesn't have cancer cells in it, we don't take out all lymph nodes anymore. That increases your risk of arm swelling, which is lymphedema. So we don't do that anymore. And even now we're taking it further to say, if we do find that there's a cancer cell in a lymph node, do we have to still take out all the lymph nodes because that patient's going to get radiation? And will radiation take care of any cells we can't see and lower that risk of lymphedema, but still treat disease and still have good outcomes? So right now we know that yes, that is true for patients who are going to have a lumpectomy. We're looking at it now for patients who have a mastectomy. Do we have to remove all the lymph nodes, especially when they're going to have radiation therapy? There are different types of mastectomies now. We don't have to, we don't remove the muscle at all, the pectoralis muscle, that chest muscle, which is really deforming. And then we can do a nipple sparing procedure where you can have a procedure done where all your breast tissue is removed, but you keep your nipple. And it doesn't increase your risk for cancer to come back by keeping the nipple because it's simply overlying pigmented skin. So it's not like you're keeping breast tissue there. But you have a good cosmetic outcome, which is something that is important to women yes, the priority is to get the cancer out, but also can we not look so disfigured? Can I still have the appearance of a woman, or femininity, it's really important to a lot of women. So we can do that procedure as well. There are so many changes with medical therapy. There's different options for patients based off of the biology of the cancer. So not all breast cancers need chemotherapy. Some cancers just need a pill, which is a hormone blocker, to block the effects of hormones, to lower the chance of the cancer coming back. There are some more aggressive forms of cancer where now we're giving immune therapy with chemotherapy because that has shown to be beneficial for patients who have like triple negative breast cancers, which are really aggressive. And that's probably one of the newest things that has come out. Radiation therapy, the same thing. Not all patients need radiation. So there are some women over the age of 70 that have these really early stage, very favorable breast cancers that they don't recommend radiation at all. There's no overall survival benefit when you compared it to patients who have it. So therapies are changing all the time, which I think is great because one of the things is that it's not like one treatment fits all, because we know that's not true, right? We can look at that with the different rates as far as the mortality rates. And so we know that all treatments don't fit for every single patient. And so it's really good that we have all this research that we're doing and advances in treatment. And it's exciting for us to be able to say that, oh, we don't have to do that anymore because because it's going to benefit the patient, So
Thank
Just
you.
to
Thank you.
aside to add to that, the reason why I knew it was so important for Dr. Bowman to answer that is I see diagnoses coming back with women obviously doing this for 30 years and having almost 20,000 patients. I see diagnoses coming back all the time. I see their treatment plans, and you can have 3 women with pretty much equal things that you see on the diagnosis, and they will have 3 different treatment plans. So, I see it completely change year by year, month by month. So I just know that it's constantly in flux. And so I'm glad you were here to answer that because it's so much more than what I would have been able to expand on.
And you know what? I'm a little biased when it comes to, Black physicians. I think one thing I have to talk about is my mom. So my mom actually, like I said, she had breast cancer when she was in her 20s, and it kind of also answers your question about mental health and, kind of, women who are going through the diagnosis and then also having to, because most women actually survive. So people think that breast cancer is a death diagnosis, but most people actually do survive breast cancer. There are more survivors than there are people that die. So that's one good thing about it. But going back to my mom, when she had her diagnosis, the doctors that she dealt with treated her like, you know what, we just gonna do what we gonna do. There was no like, what you're gonna look like afterwards, because that's a big question for women. And then also answer the other question you asked about when you get a second opinion. If you see a doctor and they're not, just like Dr. Bowman explained that to you, all the options that you have, all the, talking about nipple sparing, talking about this is your life after cancer, because you're going to, again, most likely live longer with being a survivor than you were with the cancer, and your outcomes, the things that are important to you. It's not silly to ask those questions. It's not, really immature. You're focusing on the wrong thing if you're asking about the quality of the surgeon and what the cosmetic result will look like and what your options will be, because you do have options, right? Because some people go straight to implants. Some people get what's called an expander because they want to have a little bit more symmetry. But again, you gotta listen to your heart and your soul, even though you're scared and you're dealing with a diagnosis. For a lot of people, you're going to go with someone maybe or help someone through this if it's not you. If they're telling you, I just don't feel right with that doctor, and they're really condescending and they don't answer my questions, find another doctor, because there is absolutely bias and racism in healthcare. And it's important for you not to deal with those kind of things after the fact, or feel like you got a bad result because your doctor didn't really pay attention to your needs. My mom dealt with that. She was completely, in her mind, disfigured. She was so insecure and self-conscious about her breasts, and it affected her. It affected her her self-confidence, and she was in her 20s. So find a doctor who knows what they're talking about and who answers your questions. And if those things are important to you, then definitely don't feel like a doctor can discount that, because cancer is important, but it's not the only thing that's important. So I don't know if that made sense, but
No, I'm glad you brought that up. I literally was going to bring that up, and I was like, that goes into a whole nother direction, but it is so critical, particularly for something as important as that. And I mean, just to put it in another note, because I don't always deal, obviously, with breast cancer, but I deal with fibroids an awful lot. And I see that same disparity and different ways that they'll treat a woman with even fibroids, on how hysterectomies are overwhelmingly prescribed by white male doctors to Black female patients, right? And you can see that even if you look at the way two people, a Black and a white person, walks into an ER with chest pain. So it's not that people go in inherently biased or racist, but we know that these things exist. And so it's important for you to feel that someone will treat you like they want their mother treated, their daughter treated, their sister treated. And sometimes that takes someone who looks like you. Now, we are lucky that we all live in Atlanta, because Atlanta has no shortage of highly qualified people who look like you, who will not just treat you with superb care, but literally go above and beyond because they feel that you are them. You can't put a price on it, and you can't really state how important that is. When somebody fights that extra fight for you, it can make the difference between life and death. It really will, because that person will tell you their honest, true thoughts on what you should do.
I want to stay kind of in this space of disparities, health inequity, and then with a little bit on educational and awareness. As we were talking, I was thinking about, alternatives or second opinions. Can you talk to us a little bit about clinical trials? We are in the space right now in this country where we have those who are, especially in our community, are of two schools of thought. You are either scared to death of a clinical trial just based on history, or you are scared to death of a clinical trial based on the unknown. When is it a good time to have a conversation with your provider, your breast surgeon, the person who's leading your journey about clinical trials and your ability to participate in one?
Well, my office, and not in breast cancer, but it's I feel like it's probably common knowledge, at least amongst people in the scientific community, that African Americans don't participate in clinical trials to the extent that they should. They, like you said, for the reasons that you might state, and partially because of access, just to care and to clinical trials. So although I don't have any breast cancer clinical trials, I have clinical trials related to fibroids, bleeding, endometriosis, herpes, urinary tract infections, and I strongly encourage my patients, if we are not part of it, they say, if you're not at the table, you're getting eaten for dinner. Like, you have to be part of it, so that you're aware of the latest, innovative treatments, right? And you also know that those treatments actually work on you, because there are biological differences between us and others. So I really encourage them to, and I think by having us as partners in those clinical trials, it makes it more trusting. Like, I think that I have a higher success rate of telling the patient why I think she should participate versus if the representative from the company that's running the clinical trial says something to them. I'm like, just let me and my cohorts talk to her, and you get a much higher rate because they trust. Trust is the most important factor.
Did anyone want to expound on that?
I mean, I agree with that completely. I think when it comes to breast cancer, we know that there are differences there. There are treatments that we don't know if they're effective in certain patient populations because, like Dr. Thrasher said, there aren't a lot of Black women in participating in trials for breast cancer. And some of it is that history. Some of it is that it's not even being offered to them at all. And that happens a lot. And there are studies that show that happens a lot, particularly with minority patients, that whether it's regarding treatment, surgical, reconstruction, medical treatment, not all patients are being offered just what we call standard. So there are definitely deficits because patients aren't even being offered information about clinical trials.
I have one question that came from our audience, and it's around breast cancer screening. And the question is relative to, is the 3D mammogram now considered to be the standard of care from a screening perspective?
I wish it was. It is. It's still not everywhere. And it's still not all covered by insurance. 3D is for patients who have dense tissue. So the standard is still the 2D mammogram, where you look at the breast from the side left to right and then top to bottom. With the 3D, you're able to see through the tissue and it removes some of that overlap. You get less callbacks. You get a increased accuracy as far as finding there with diagnosis. But I wish that everyone could get a 3D mammogram, but there are still specific criteria that they want you to have before they will do them.
Thank you. Another question for anyone on the panel. We talk about things that in our community that we tend not to have holistic conversations about, even though we're getting there, and mental health was one of them. The second is breast cancer and its prevalence in men. Can we talk a little bit about men and breast cancer diagnoses, and more importantly, how prevalent is it in the African American community? Dr. Fletcher.
I was about to say Dr. Bowman. That's all.
Okay. So breast cancer, are we there? Do we freeze? Okay. So breast cancer happens in men. It is not common. It's still like less than 1%. So it's like 1 in 883 men over their lifetime will develop breast cancer. It can be related to, or more commonly, I guess it's more related to family history, like genetic factors. So we always want to test a man, or if it's a woman who knows that there's a man in her family that had breast cancer, we want to test for a genetic mutation to see if there's one of those that would increase the risk for breast cancer, and particularly male breast cancer. It can be, or at least we're looking into factors like still the same as it would be with a woman, obesity, right? Or like liver disease, alcohol-induced cirrhosis, anything that basically causes an incomplete breakdown of estrogen. You have this unopposed estrogen, and that increases, and estrogen can increase your risk for breast cancer, right? For developing breast cancer. But men do get breast cancer. Men don't need to have screening mammograms because the risk is so very low. Even if there's like a family history, they still don't need to have screening mammograms. Usually when a man has a breast cancer, it's found with an exam with a lump palpated on the chest. But there's still no standard as far as screening for men for breast cancer because the risk is just so low. And when it comes to Black men, the risk is still very, very low. It's not higher in Black men.
There have been some reports and stories in the media over the past, I'd say 2 or 3 years, relative to women having what I would consider to be proactive removal of breasts as a method of breast cancer prevention. Can someone, talk a little bit about that? And I've read about it and heard about it, especially those women who have genetics and history of breast cancer in their families. And how often does it happen? Is it recommended? Just talk a little bit about, what's in the studies, what's in the science, and if you've had anyone in either of your practices kind of talk about it.
I can start with that because we do a lot of the screening, but I definitely am going to need to defer to Dr. Bowman after with respect to the recommendations that she might have. Usually I sort of get it started and I will offer some recommendations, but I always, if anything is positive, meaning BRCA1, BRCA2, which I'll talk briefly on, I always then defer and say, I'd like you to meet with a breast specialist so that they can tell you if there are any later or more up-to-date recommendations, and also to sort of like integrate that with the family history and other things and the patient anxiety. And just there are a lot of different things that make people decide what they want to do with that information. So what we do is we screen all of our patients when they come in. We have like a card that has like 5 questions. Anyone in your family had breast cancer, ovarian cancer, a series of like screening questions, because there are tests for it, but your insurance company won't really cover it unless you sort of qualify with certain criteria. If they qualify, or if they don't and they are willing to pay the cash price for the test, then we do a blood test called BRCA. BRCA1, BRCA2, and that will tell you whether or not they have a variant or a mutation in those genes located on chromosome 13 and 17 that will increase your incidence or lifetime risk for breast cancer and ovarian cancer, which we also, obviously think about in GYN. So if it comes back with a mutation, then we offer some of those women, we offer all of them options of, depending on where they are, the age, desire for childbearing, so those things come into play, right? A 20-year-old may have a whole different take on it than somebody who's completed childbearing, but we offer them risk-reducing procedures, whether or not that's removal of the ovaries, or obviously if it's something related to breast, then I'm going to defer them to make sure they speak with a breast specialist who would talk to them about whether or not they want to do risk-reducing procedures. I've only, in the time that I've been practicing, maybe had 3 or 4 women that have taken me up on doing that. So it's not something that they grab onto, but again, I think a lot of it is related to age and whether or not they've had children. We were talking about the risk factors earlier, and I do want to defer to Dr. Bowman in this, but a lot of women, obviously, as we know, come through, and we're all sort of in our 20s and 30s, still getting our career together. And so by the time they're 30, they still haven't had a family. So, it's so different than 20 years ago, I'm sure, when people were sort of finishing families at 30. And now most of my patients don't have a child at age 30. So, that conversation that you would have about, well, we can remove the ovaries to reduce your risk, or remove your, breasts and all of that. It just means a whole different thing to somebody who's not started their family. So I'd love if, Dr. Bowman can sort of expand on some of the things she would offer and when she would offer.
So generally, when patients come to see me, they can come after like having genetic testing done with a known genetic mutation, or they come sometimes just when, like, Dr. Thrasher does an excellent job doing her own screening. But sometimes they'll say, well, you have a family history, so many members in your family, you need to be screened by a breast specialist anyway, because even if genetics comes back, you're still high risk, because we don't know everything. So the most common genes that we test for are BRCA1 and 2, but now we test for over 70 genes. There's panels of genes that increase your risk for breast cancer that are on genes that we're knowing. Again, this is one of those advances in treatment, right? Advances in therapy, because they constantly test these genes to see if there's mutations. So we know the BRCA1 and 2, everyone knows those two most commonly, but there's CHEK2 and PALB2 and PEG10 and BRIP and MBN. And there's so many that we test for to see if you're increased risk. If you fall into one of those categories where you have the genetic mutation, then we talk about how we screen. And everyone doesn't jump to doing a prophylactic mastectomy, although it's part of the treatment plan. There's a whole kind of spectrum where we follow you as high risk. So on one end of it, it might be for that person who is maybe not ready to commit to removing the breast, because maybe they do want to have another baby and try breastfeeding. And so we still monitor you with doing breast exam twice a year, and you're getting a mammogram every year and an MRI every year, and really close screening by probably myself or a breast specialist, but also if you have a gene mutation, you're probably going to be seeing closer for any risk as far as like ovarian cancer, or if it's a colon cancer, you're going to see other specialists as well. And then on the other end of that spectrum is to do what we call a risk reduction or risk reducing mastectomy, where we remove all that breast tissue. And when you do that, your risk doesn't go down to 0. I wish it was a guarantee, but it is significantly lower. It's a drop that's less than the risk for a person in the general population. So where you have like some of those BRCA1 and 2 gene mutations, where your risk of breast cancer is as high as like 85, 88% over your lifetime, that would be your risk, where the risk of the general population is 1 in 8, which is 12%. When you do that risk reducing mastectomy, remove all that breast tissue, then your risk goes down to less than 1 or 2%. I mean, going from 88% to less than 1-2%, that's a significant difference. That's going to change your overall survival when it comes to breast cancer risk. So that's why we recommend it. But all patients aren't don't jump to it. So there are many patients that we just see in the office, and we follow them until they're ready. The national guidelines typically they say after age 35, which is because I think that was the designated advanced maternal age, right? And you can comment on that more, but at 35 is when they want us to strongly consider doing these prophylactic procedures.
Because you're elderly, Gravit.
Because you're elderly, right?
You're an elderly pregnant woman at that point.
I
But
still don't like that term.
Right. It's funny. So I actually was one of the rare ones who had that surgery. I did. I had a nipple sparing prophylactic mastectomy. So yeah, my mom, again, so what I scored pretty high on that screening, and so I did see it. So the steps are, after you do that, you do like a little survey, and then you get categorized, and then they send you to a geneticist. Like there's actually a genetic doctor whose job is to counsel you about your risk, because we don't, in medicine, like we don't do that. We don't know, like is a billion genetic things that are out there, and there's so many different variables that determine whether or not, even though you have a genetic predisposition for something, what makes it actually show up as a disease. And so there's specialists whose job is to kind of know that. And so I went to see this special doctor, and she told me, well, have your mom come and get tested. And my mom said, just like a lot of Black people say, in the name of Jesus, I rebuke that. And I'm not going to have you worrying about that. And so she would not get tested. And I had a mutation that she said, if your mom has the same mutation, then it really is significantly important. But it was back before, every year there's more and more information that comes out. And so, so I had this genetic kind of mutation that was, at first it was called undetermined significance, but then was like one of those random numbers. And I was a person who also had a mammogram, MRI, or ultrasound literally every 3 to 6 months. It was ridiculous. Like I would go, by the time I finished getting my ultrasound or MRI, it was time to get another mammogram. And so I remember when I had my surgery, I'm 45 now, so I think I was 41 or 42. The radiologist always, like there's so again, I really advocate for offices like Dr. Bowman's, because you go and you get, the screening, and then you usually get an answer like pretty much almost immediately. You don't have to do that waiting around for weeks or a letter in the mail like I used to have to do when I was in the Navy. But anyway, so then I had a positive MRI, and they found something behind my nipple. And then I had an ultrasound, and the radiologist was like, I think it's okay, but we'll just check it up, follow it up for 3 months. And it was just nerve-wracking. I was doing this all the time. So the last mammogram I had, I said, I'm going to do this surgery. And the radiologist said, I would do it too if I were you, and I've never thought about it again since. And I'm so happy I did it. Fortunately, I did have nipple sparing, and that was really important to me, because I was someone who was concerned, like, I'm going to be living probably much longer than I'm not. So it was important for me to be able to do that. I didn't care about the big breast, because I'd always had a small chest, but it was just that fear that I constantly was living with. So I was pretty happy. But one thing that was disappointing for me was that my mom would not get tested. And so it kind of led me down this road to really loving data and research. And that's why I went and got a degree in public health. And I actually work for a pharmaceutical company. I do a job called pharmacovigilance and medical safety. And my job is actually to essentially look at the data and to constantly look at the medicines that are our medicines, and make sure that there is nothing that's an adverse event that's associated with it. New information that comes in that is saying, hey, in this population of people, there's a higher risk of negative outcomes. That's important, because for us who are not participating in medical research, a lot of times it's after the medicine gets approved that there's a problem that's detected. And you don't know, in certain populations that decide to get research, then it's found to be safe in them. And so the FDA approval is based on the people who actually were participating in the clinical trials. But then it's out on the market, and then there's populations of people like us who maybe there's a different adverse experience. And one of those kind of, the data that has kind of come from that we all kind of know about in medicine is high blood pressure medicines. We know Black people do better on calcium channel blockers and thiazide diuretics, right? However, Back in the day, we would just prescribe anything. But it wasn't until that we got the post-marketing data that said, hey, in this population of people, your blood pressure is not going down. So say, for instance, Black people would have been participating in the clinical trials, for these other medicines, they would have known a long time ago, and there wouldn't have been wasted time and wasted kidney failure and wasted blindness and wasted strokes for people being on a medicine that was not working for them. So that's the benefit. Sometimes the benefit is that we get information that says, hey, this works really well in Black people, and this does not work well at all in Black people. This chemotherapy medicine works really well with this type of cancer, and it does not work well with this kind of cancer. If people don't participate in clinical trials, we don't know that. So that's just a little aside to kind of advocate, but that's the benefit. People always think about the risks of clinical research, but the benefits are we sometimes can do what's called precision medicine. We know what works really, really well for you because we have tested it in you and we know it works well. We know now high blood pressure is there's a different age. Like when people are elderly, right, they're allowed to have a higher blood pressure. We're not so aggressive with their blood pressure. That's only because, again, it's data, is information that's come out of clinical trials and research. So it is to our benefit to really participate, because if not, we keep getting the short end of the stick. We are basically, by living in a world where all the stuff that's out there is for someone other than us, we are guinea pigs. It's kind of like we're left-handed people living in a right-handed world, right? So that's the point. Like, if we're not participating in the trials, we don't know what our adverse experiences will be until we're actually out there and it's already FDA approved. And so just something to think about.
Ladies, I have loved this, and our audience absolutely are all the better for it. I cannot thank you enough on behalf of Camellia Rose for your insight, your knowledge, your candor around all things breast cancer awareness, clinical trials, mental health, nutrition. Before we close, I would like each of you, if you don't mind, provide us one or two little closing nuggets that you want the audience to take away as we go on into the evening. And Dr. Metcalf, I'll start with you.
Oh, that was mine. Participate, because if not, we are getting left out. So that's all.
All right. Thank you, Dr. Bowman.
A couple nuggets. One is if you if you see something, you notice something, say something, don't ignore it. Talk to a healthcare provider and don't be afraid. More commonly, it's not going to be something. It's not going to be cancer, but you don't know that. And if you ignore it, then something that could be, if it is cancer, that could be treated and cured, might be at a later stage where treatment options are limited. And then the other is to be your own health advocate and speak up for yourself and ask questions and get your questions answered, and don't just settle.
Thank you, Dr. Thrasher.
So I would say two things. One is just remember a three-prong approach. You have to examine yourself. You need to be certain that someone else examines you, and please be certain to get your yearly screening, particularly as of age 40. And the second one is to, as we stated before, as an OBGYN, I would just say that, and it doesn't have to be an OBGYN, but what I do notice is that when people get older or a certain age, or if they're not in the childbearing phase, they feel like they don't have to get certain things checked. For some reason, they feel like they don't have to get breast check or vaginal check. And even the United States Department of Public Health even starts to tamper with that a little by saying you don't have to get pap smears or certain things after certain ages. And what that does is it makes women say, I don't have to go for a wellness visit or an annual, because they equate annuals with pap, but they don't realize that part of that exam is the breast check. So I always tell my women, regardless of your age, you need to have a very intimate relationship, no pun intended, with your OBGYN, because they are the ones that are going to check you very, very thoroughly in the areas that most internists won't. I mean, they are great at the blood pressure and all of this stuff, but most of the women that I talk to who go to an internist, when I ask them what they checked and didn't, they will come to me after 3 or 4 years and they'll say, well, they didn't check that. So they listen to my heart and lungs and they were great at that, but they don't really like disrobe them and do a thorough breast, and they certainly don't disrobe them from the waist down. So I just really feel like they should have an internist or someone in that part, but I really feel like all women should really continue to see their GYN, because that's where they're really getting the preventive early diagnostic testing from for that part. Just my opinion, might be a little biased, but I see it firsthand.
Can I just,
yes, come on.
I'm going to add on to that because it just went with it. But for women, the two biggest risk factors for developing breast cancer are being a woman and getting older, and we can't change those things. So absolutely go see your OBGYN who's going to do that thorough breast check, and you should do your self breast checks as well, because we can't change that.
Thank you. I know we're a little over time, but I have 2 questions from the chat that I must get in. So one is, if you have a history, meaning your mother and grandmother both had breast cancer, would you recommend the person having genetic testing done? Okay.
I'm sorry, say it one more time. I think I was looking at the comments and someone, because I was like, I didn't even realize it. I didn't even realize the comments were there. And someone asked what the medicines were. So thiazide diuretics and calcium channel blockers are the two blood pressure medications that typically work best in people of African descent. And most doctors know that. That's kind of clinical standard of care. That's clinical guidelines. But thiazide diuretics and calcium channel blockers. And what was your question? I'm sorry.
Oh, no worries. I was asking that if a person who has a history of breast cancer, more importantly, their mother and grandmother both had breast cancer, would we recommend having genetic testing done?
So there's a clinical assessment that typically it's actually like a survey, like a questionnaire that you fill out, and that is an assessment that kind of categorizes your breast cancer risk. And so then after that, if your risk is higher, then that's when you're kind of sent to the geneticist. And then that is kind of how it happens, because, it's again, BRCA1 and BRCA2, just for people to understand where that information came from. It came from a group of Jews, basically. Ashkenazi, I think it's Ashkenazi. I always say it, Ashkenazi. I never say it right. I know what it is, Ashkenazi Jews, but it's not. Again, that's something that was found in that population. And so there are so many genetic mutations that are out there that are more than BRCA1 and BRCA2, and actually in our population. And so one thing that too, if you have a family member, I forgot to say this, if you have a family member who did have breast cancer, please compel them to get genetic testing. And people think it's not important. Oh, I already have it. But it's important, because we cannot just take your DNA. We can't just do that and do that genetic test. That's not, that's kind of the Henrietta Lacks thing. You got to get consent. So people think that we can just take the information because you had the, path, like you had the surgery, but you got to agree to do that. So one, do this questionnaire and see if your risk is still higher, because again, like the doctor said, the risk is being a woman and growing older. And so when did your mom or your aunt have breast cancer? Because, if they were older than 60, 70, then it's kind of like that's, it's probably spontaneous. So if they were young and a lot of young people in your family had it, and then they also had other kinds of cancer, then that's a different conversation. But that's why those surveys are really important, and your doctors will have access to them and they can help you with that.
Thank you. And one last question. Is it true that women of color are most likely to test positive for the triple negative? And if so, what is there a cause for that? Do we know?
So triple negative is one of the most aggressive forms of breast cancer. We are seeing it more commonly in younger women. We see it more commonly in Black women. We don't know why. That's one of those things that needs to be studied, is why. We see it's usually diagnosed at later stage of disease. And like I said, it's more aggressive. So, but it is something that is more common, but it's not. We don't know why we're seeing it more in Black women. There is an association with genetic mutation with triple negative, but that's not the majority.
Well, ladies, we cannot thank you enough again. We're so appreciative that you joined us with all of this wealth of knowledge and information this evening. To our audience, thank you for hanging in with us to get the knowledge and have any questions. Two things will happen. Number one, we'll be putting a SurveyMonkey link into the Facebook chat for your feedback. And then also, we're going to provide some information on some resources where you can find more information around breast cancer awareness, screening, and education. This information will also be placed in our chat for you to go and get that information. And then also to reach out to these ladies if you have any questions or need any further follow-up. Again, ladies, thank you on behalf of Camellia Rose, chapter of the Links Incorporated. We cannot thank you enough. Thank you for partnering with us. And for everyone, have a very good night. Be well and be safe. Thank you.